My name is Abby Budavas, and today I'm going to be speaking to you about body mechanics and transfer skills. The definition of body mechanics is the proper body movement and position to prevent injury and enhance performance during daily activities, including lifting and transfers. This is an overview of the anatomy of the spine. Important things to notice are that the cervical spine, the thoracic spine, and the lumbar spine are the three major curvatures of the spine. The cervical and lumbar curvatures are concave, and the thoracic curvature is convex. Innately, the spine is sort of weak on its own. I like to compare it to a string of pearls, which, if you wiggled a string of pearls holding it up, is very unstable in and of itself. Each individual vertebra, which are the individual bones that make up the spine, are connected by muscle tissue. In between each individual vertebra are small segments of muscle. Some of them are paraspinal muscles connecting multiple levels. The way that people get injured is by not maintaining those natural curvatures of their spine, and by bending forward and then contracting only single units of the muscles as they're standing up, they're more likely to injure themselves. So by maintaining the natural curvature of your spine, where your muscle is at an inherent advantage, mechanical advantage, you're able to protect your spine from injury. Maintaining good posture is very important as the basis of having good body mechanics. Poor posture can cause muscle tension, stiffness, fatigue, backache, and neckache, and it also contributes to degeneration of discs and ligaments, causing chronic pain. In order to have good posture when sitting, standing, or lifting, it's important to have your ears lined up over the shoulders and the hips. This maintains the three natural curvatures of the spine. To maintain good posture when performing a task, it's also important to stand close to the patient so that you don't have to lean forward and ruin that good posture. And also using your hips and knees and your bigger leg muscles and hip muscles to avoid arching and bending at your lower back in order to maintain those three natural curvatures of your spine. It's very important whenever you're bending, lifting, or transferring to ensure that you have a nice broad base of support. So in other words, you want to have your feet very wide apart so that you have good balance. A good example of this is the pyramids in Egypt have a nice wide base of support, and they've lasted for centuries. They're unable to topple over, as compared to the Leaning Tower of Pisa in Italy, which has a narrow base of support and is naturally just falling over because of gravity. So we want to use those same principles when we're thinking about the lifter who's assisting the patient. We want that person to have good balance in order to protect themselves from injury. There's a lot of focus on the lumbar spine and the low back for prevention of injury, but we don't want to forget the cervical spine and upper back. In our outpatient PT clinic, we often see the most common injuries from improper lifting and improper body mechanics are upper trapezius and neck strain. In order to protect your cervical spine, your neck, and also your upper back, it's important to maintain that neutral posture that we've already talked about. So avoiding any neck rotation, side bending, or excessive extension or flexion while you're lifting is very important. Also, you want to be sure when you're actually shifting a patient or any sort of a load to be shifting from one foot to the next rather than overusing your biceps muscles or your upper trapezius muscles by shrugging. You do not want to be lifting up with your arms and your shoulders. You want to be just shifting from one foot to the other. Additionally, your shoulder blades should be sort of down and back. That's what we call retracted, and maintain that in a neutral position to protect that upper back and cervical spine. These are the basic principles of any transfer. The first thing is keeping your feet far apart from one another. Depending on what type of transfer you're doing, you're either going to have your feet far apart side by side or one in front of the other. But the basic principle is that you're going to be shifting your weight from one foot to the next. So it's important to have your feet far enough apart. The next thing is bending at your hips and knees rather than your low back. You want to make sure that your back is slightly arched and that you're really using your quadriceps and your glute muscles as well as your abdominal muscles to do all the work. Finally, you're going to make sure that you are nice and close to the patient or whatever heavy object you're lifting. That way there's less torque pulling you forward at your back. If you keep the load nice and close, it's a lot less work for you. Then when you're actually turning to transfer the patient or the load to a different surface, make sure that you're keeping that good posture the entire time and also picking up your feet so that you're not tempted to just twist at your lumbar spine, which puts you at high risk for injury. When you're assisting a patient with a transfer, it's very important to remember to always plan the move before you begin, to obtain extra personnel as necessary, to ensure that the transfer surfaces are level with one another, ensure that the wheels on the bed or the chair or the stretcher are locked before you begin, tell the patient how the move is going to be accomplished, ask the patient if they're able to help you, and remember that the patient's center of gravity is in their hips, so that's a good place to be assisting them. Never ever pull on the patient's arms. That risks dislocation of the shoulder. And finally, when transferring a patient out of bed, make sure to allow them to rest sitting at the edge of the bed for a few seconds to minutes to ensure that their blood pressure has adjusted. When performing a bed to stretcher transfer, it's very important to have at least 2 people, though 3 people is even better, helping with the transfer. And if the patient is a person of size, it's important to get even more than 3 people to ensure that the patient is going to remain safe. It's also important to utilize a slide board to reduce friction during the transfer from the bed to the stretcher, or vice versa. The first step is moving the patient's feet and legs in the direction that you're going to be transferring them. It's also important to have the patient cross their arms across their chest so that their arms aren't dangling all over the place. When you're getting ready to actually transfer the patient, it's important to use an underhand grasp and choke up on the sheet so that your hands are right next to the patient. It's important to communicate with the people that you're transferring with, and someone should be designated as the one to call out 1, 2, 3, pull. And on that word pull, everyone should move the patient in one uniform force to get them from the bed over to the stretcher. As you pull, your weight should actually be shifting from your front foot to your back foot instead of overusing your biceps or your shoulder elevators. Finally, if the patient is very large, it's okay to move the patient in 2 steps. So the first step would be having the patient move from the bed onto the slide board, and then the second step would be having them move from the slide board all the way over to the stretcher. When assisting a patient from a sitting position to a standing position, the most important thing you want to remember is that you're trying to get the patient's center of gravity and their center of weight, which is in their hips, over their base of support, which is their feet. So it's important to note that you're actually trying to get the patient's weight forward over their feet. Therefore, if the patient's hips are tucked far back in the chair or the patient's feet are far, far in front of them, it's going to make the transfer a lot more difficult for both the patient and the person assisting them. So the first step in a sit-to-stand transfer is having your feet far apart so that you have a nice and stable base of support, and then also having the patient bring their feet in towards them and having their feet far apart so they also have a nice stable base of support. The second step is having the patient place their hands on the surface that they're sitting on. So it can either be the edge of the bed or the chair or the armrest of the chair. They should absolutely not ever be putting their hands up on the walker or any other assistive device in front of them. because that's not inherently stable, and they're not able to push up through their arms to help with the transfer. It's important to encourage the patient to scoot their hips towards the edge of the surface, again, to help get their center of gravity forward over their base of support. It's important when you're assisting the patient to bend your knees, maintain that natural curvature in your lumbar spine, and push through your quadriceps and your thighs and your buttocks to assist the patient into a standing position. Ensure that the patient is ready to move prior to assisting them. And then on the signal 1, 2, 3, stand, the patient should be pushing off with their arms and also down through their legs, and you should be helping the patient's center of gravity, so their hips or their waist, actually come upward and forward. You should never be pulling on their arms to assist them. When assisting a patient to transfer from bed to chair or bed to wheelchair, the first thing that's very important is planning your move and ensuring that the environment is all set up. So that means locking the wheels on the bed, the wheelchair, or the chair to ensure none of that is going to be moving while you're attempting to transfer the patient. Also, adjusting the height of the bed so that it's appropriate to make the transfer easier for you and the patient. Whenever possible, you always want to transfer towards the patient's strong side. For example, if the patient had a stroke and they're hemiplegic on one side, you want to go towards their strong side. Or if the patient had an orthopedic surgery on their leg and they're non-weight bearing on one side, you want to be transferring towards their strong side, even if that means having to move the position of the wheelchair, the chair, the bed in order to accomplish that. So the first thing that you'll do is use the sit to stand technique that we already reviewed in the previous demonstration. The next step is to assist the patient by holding onto their waist or perhaps their buttock if they need a little bit more assistance with standing. I really discourage the patient holding on to you. However, if they absolutely must, they can hold on to the inside of your elbow. That way you can hold on to the underside of their elbow and they can push down through your arm. That way they're not pulling on you, the assistant, and compromising your ability to assist them, and they're not compromising your body mechanics. Once the patient is standing and you're ready to actually pivot and have them take steps to the chair, you want to pick up your feet in order to accomplish that, and also encourage the patient, if they're able to pick up their feet to be able to back up to the chair. And then prior to sitting down, you want to encourage the patient to reach back to the armrests of the chair and slowly lower down into the chair. You want to keep your knees and your hips bent as you slowly lower the patient down into the chair. Do not let them pull you down and compromise your body mechanics as you're assisting them. You want to bend at your hips and knees. Once the patient is in the wheelchair, it's important not to compromise your body mechanics when you're actually pushing them around the hospital. So after the patient is seated in their wheelchair, it's permissible to use safety straps as needed to make sure that the patient remains safe and isn't slumping out of the wheelchair. The patient's arms should remain on their lap. They should not be dangling outside of the wheelchair, getting caught in the wheels. Whenever you're pushing the wheelchair, it's important to maintain good upright posture. You don't want to be rounding your shoulders forward or leaning forward excessively when you're pushing the wheelchair. You want to maintain that good standing posture. Whenever you're going through doors, or non-automated doors, it's important to open the door and then back the wheelchair through the door. Be cautious around corners and doorways so that you're not going to run into other pedestrians and you're not going to accidentally clip the patient's feet as you're going around corners. And also being aware that there are mirrors placed in the hospital for those exact purposes of avoiding collisions. When assisting a patient into their car after discharge, it's important to ensure that the front seat of the car is pushed all the way back so that there's plenty of room for the patient to be able to swing their legs into the car. The car should be parked at street level, and it should be parked several feet away from the curb so that there's plenty of room for the patient to mobilize when backing up and getting into the car. The door of the front seat should be opened as wide as it can, also to allow room for the patient to move and get into the car. The first thing to instruct the patient to do is to back up to the frame of the car and to the seat they're going to be sitting in, so that the back of their legs is touching the frame of the car and ideally touching the seat that they're going to be sitting in. Then instruct the patient to reach back with their hand to the back of the car seat, and with their other hand they can reach back to the dashboard or maybe the seat of the car, whatever seems more natural for the patient. And then they can lower themselves into the car. It's very important that the patient never holds on to the open door because it can move and is very dangerous. So they should be reaching back for the actual frame, the stationary parts of the car, before lowering themselves down onto the seat. Once seated, instruct the patient to slide themselves all the way back into the car as far as they can, at which point they're perpendicular to the actual direction of the car seat. Next, the patient is going to turn themselves and lift their feet into the car one at a time. Sometimes the patient's clothing can create friction with the seat, especially if it's a fabric seat, and it can be difficult for the patient to perform that pivoting motion. A simple trash bag placed on the seat of the car can help to reduce that friction. So now the patient should be facing forward and they should be nicely tucked into the car. Two important diagnoses to keep in mind are: one, if the patient has had any sort of open heart surgery and has sternal precautions, they should not be sitting in the front seat of the car for any reason. They should be sitting in the back seat of the car. The same principles can be used for getting into the back seat of the car. The other diagnosis that's very important to keep in mind is any patient who has had a total hip replacement with posterior hip precautions. Posterior hip precautions include the patient should not be flexing their hip more than 90 degrees, and sometimes it's difficult when getting into a low sedan-style car to maintain that hip precaution. In order to overcome that, a firm pillow can be placed on the seat to make the seat height higher as the patient is getting into the car.